Hello and good afternoon everybody, and welcome to our learning lunch for June. My name's Sarah Mitchell and I work at the LGA, and as colleagues who've joined us before will know, we have a monthly learning lunch where we want to present best practice, hear from speakers who are doing work at a national level and a local level, but also just stimulate our thinking, whilst hopefully you've got something to drink and something to munch whilst we have this conversation. Hope you had a really good weekend. I appreciate a lot of you will have been working over the weekend, but I hope you got some time to have a bit of a break. Coming back in, I'm certainly trying to channel some of Louis' energy for the week ahead and make sure that we're having good conversations about some of the things that we're really working and sometimes struggling with at the moment. So on that note, I'm absolutely delighted to introduce Professor John Bolton to you. Many of you have met John before, heard of him, read his work, and John is going to take us through a presentation, what is reablement, the question we're all asking, and expand on that with us. Please put any questions that you've got in the Q&A. We'll be looking at those and I will be putting those to John at the end of his presentation. This is a live event, so we go through and hear from the speaker and myself, but it's not a Teams meet where you put your hand up and ask a question, so please make sure you put them on there. If this is something that you're struggling with in your system, you want a bit of support, you want to be put into touch with other places of best practice, we'll put an email address in the chat for you to contact us if you want further support. And Frankie has put in the feedback questionnaire that we really welcome, because we want to improve and develop these events, so welcome your views. And if there's anything you want us to talk about in the future, we'd be really keen to hear from you. So without further ado, I pass over to John and ask you to introduce yourself and your presentation, John. Thank you.
All right, good afternoon, everyone. I'm very pleased to be here talking to you about reablement. I was once called the grandfather of reablement because I gave a first presentation about reablement at a Directors of Social Services conference in 2002, so 20 years ago. But I'm going today to talk to you about that. My background is that I'm currently a visiting professor at Oxford Brookes University. I work as a consultant. I'm mostly these days focused entirely on D2A, on discharge to assess. I'll say a bit more about that in the presentation. But I have been a director of social services. I have a career, my background was as a social worker. I have a career in social care. I worked for a while at the Department of Health. And as I say, the last 12 years doing research, writing papers, developing ideas of how we might better run the system. So this is a backtrack through history. So let's start with the first slide, which takes us to the kind of origins of reablement. Frankie, can we have the first slide? Thank you. So I think it's quite interesting to note this is a really very recent concept. In fact, I don't think the word reablement appeared in the Oxford Dictionary till about 2 years ago. It kind of emerged out of thinking that late 1990s, early 2000s. I was first drawn to it by a study by De Montfort University published in the year 2000. Julie Kent and others wrote a study of some work being undertaken by Leicester Social Services Domiciliary Care Services, and how they were able, by working with older people in particular ways, able to help those people get better, need less care, make some kind of recovery. And that really supposed to set the scene, because it introduced, particularly in those days, it was a social care concept, the idea that older people can make a full or partial recovery from a physical or emotional event that otherwise would lead to the person requiring care. At the same time, there was work going on, particularly I would draw your attention to the work at Newcastle Institute of Aging. They did a number of studies showing how if you get the right help to people at the right time, you can reverse the loss of ability. You can reverse people's decline in disability. And you can help people to undertake more activities of daily living if you're over 85. And they produce papers and work on this right through particularly that decade. And then I suppose reablement became the norm for social services in this, because it was published in the Department of Health's Social Care White Paper in 2005, which was called Promoting Independence and Choice. That really put reablement at the heart of what social care should be doing, and was quite influential. Next slide, please. This is the life curve that Newcastle University Institute for Aging produced, which showed that the difference you could make to the quality of and extent of people's lives. The blue curve on the diagram is if you've had an intervention that can help reduce your disability. The grey curve, the darker curve, is what happens if you don't intervene in people's lives to help reduce their disabilities. And on the left-hand side are the skills of daily living into which you could help people. And this certainly in my work, in my thinking, this is a very important piece of work, and still holds that they actually produce some software to go with this, which is quite widely used in Scotland. Next slide, please. The next thing is worth saying is that actually people then began to realise not only was this a good thing, but it actually had quite a big impact on the efficiency of social care. And in 2005, the Department of Health set up a Care Services Efficiency Delivery Programme, CSED. And it was kind of supported by the Treasury in order to try and demonstrate how we could make social care more cost effective and deliver savings. And one of the programs that this CSED developed was a domiciliary care reablement program. In fact, the program demonstrated that it could reduce spend. If you got good domiciliary care reablement, you could reduce spend on adult social care by around about 10%. And it could make a combination of reducing demand on longer term care at home and reducing emissions to residential care. Again, I'll say a bit more about that. So that was kind of pretty important part of the culture, and pretty well every council that was looking to how it could demonstrate its efficiency then began to develop its own reablement services. And as we know, in recent times, 2010 onwards, many consultancies, many people working in the social care field, I'm sure a lot of you will be familiar with the work of Newton Europe, for example, who developed a whole methodology around developing and making the delivery of services more cost effective, particularly getting the efficiency into the running of domiciliary care reablement, which has its own challenges. And again, they continue to demonstrate that if you could do this, you could have a cost-effective service, it would reduce the costs on social care. Next slide, please. In a way, what we're talking about, and this is where I think reablement gets confusing and confuses and almost confuses itself. There are four concepts which actually are different sides of the same square. There's the concept of people recovery. People who've been, for example, in hospital need a period in which to recover from the interventions that they've experienced. The same with recuperation. Part of that recovery requires that people have a period of recuperation, a period of rest, a period of to regain their strength. Some people, or many people, actually need, as part of that, rehabilitation. The physiotherapists, occupational therapists, other therapists helping people to rebuild muscle strength, redevelop their confidence, begin to look at how they're going to face their life beyond the incident that took them into hospital. And then in exactly the same kind of conversation is reablement. Reablement is in fact all of those three things together, but delivered by domiciliary care workers. So trying to support people in any of those fields. I'll say a bit more about that on the next slide. Next slide, please. As we have learned more and more, we see actually there is a massive overlap between what therapists do and what domiciliary care reablement is doing. In fact, well before anybody discovered domiciliary care reablement, therapists had been for decades trying to help people regain strength and confidence to regain or retain independent living beyond events in their lives, or just as life catches up with people and they begin to deteriorate. There are opportunities to help people to rebuild. And what domiciliary care reablement did was gave a way in which frontline care workers could participate in helping people with those programs and begin to help older people to make a full or partial recovery working. And the evidence is clear. Domiciliary care reablement works best when an older person is being helped by frontline care workers, but under the direction of a therapist. And we'll say a bit more in a minute, but actually, if there isn't that therapy input, if there isn't that clarity of purpose and clarity of intervention, domiciliary care reablement can become no different to ordinary domiciliary care. It can be very caring and supportive, but it is unlikely to make the impact of helping people to make a recovery. And that's kind of almost becomes the difference between standard domiciliary care that someone might receive and domiciliary care reablement. It certainly had a big impact on thinking about the way in which older people are helped. Kind of helping older people to do more for themselves, and seeing that actually there was a big Canadian study in 2002 which actually demonstrated that in simple terms, when older people stop doing things for themselves, they are likely to deteriorate and they will need more care. So the whole emphasis is actually at what point do we encourage older people, encourage people to make a recovery, and at what point do we kind of give up? When we give up, when we say actually enough's enough, this person can't benefit any further, then they're likely to deteriorate. In fact, the Canadian study actually said we increase the likelihood of death when we give up on people. So it's quite a big impact on people's lives. Goes back to that graph from the Newcastle Institute of Aging, showing that actually if you don't intervene in people's lives, their life cycle is going to be worse and they're going to die earlier. And the evidence is compelling. I think that the research evidence, there was a big study by the Personal Social Services Research Unit, which clearly showed that good, effective domiciliary care reablement had to be led by therapists. And if you could get that right, about 2/3 of older people would make a full or partial recovery. People weren't going to recover fully back to the state they were in maybe before they'd had a medical intervention, but they'd make sufficient recovery, particularly to return home. And I think those figures still stand today. The best domiciliary care reablement services I see achieve that kind of figure, about 2/3 of people. Probably worth saying, in 2007, the then Department of Health put out a paper called Putting People First, a policy paper, and again, reablement was the heart of it. So really, that was kind of almost the peak of domiciliary care reablement at that period in history, and we can say a bit more about what's happened since. So next slide, please. So in the 2020s, we kind of now have D2A, discharge to assess, as for example, as the mantra going with hospital discharge. Actually, the term I use is D2RA, discharge to recover and then assess. So the whole purpose of a out of hospital care system should be to help people's recovery. Now, again, the terms we used before, recovery, recuperation, rehabilitation, reablement, all come into play. And as I'm suggesting, the evidence is clear that if people have been through a trauma, they may require a period of recovery, and before an assessment is made for their longer term care needs. And it's that period of recovery. If you're just waiting for an assessment, if it is purely discharge to assess with no recovery, then actually the assessment period, the person might decline. They might, makes very little difference to their lives. So it's not the period waiting for the assessment that matters, it's the kind of levels of recovery that people are offered. So it's not a passive period. It's not waiting for an assessment, but it's an active period where frontline care workers, supported by therapists and nurses, can support older people regain strength, regain confidence, looking to see to what level of recovery they can make. And this can happen in an old person's own home, which is where domiciliary care reablement matters, but it's equally important that it happens in bedded facilities, community hospitals or care homes. Where a therapeutic program is offered, there is a 70% chance of the older person will return home. Where there is no therapy or support to recover offered, there's an 80% chance the person will remain in a bedded care home. My own father-in-law has been in an intermediate care bedded facility for the last 3 weeks. And it's been very interesting, partly because I've been pushing for it. An OT has visited him and done an assessment with him and shown him things he can do. The OT suggested a physio came to visit him, and they came to see him, and they particularly showed him how to use his walking frame. But the staff in the care home, who are perfectly good carers, perfectly able to do their day-to-day tasks, have no training and no drive to actually work with my father-in-law to help his recovery. So though he gets these one-off sessions, and particularly because he's got a bit of dementia, that doesn't help him in remembering these things, there's no one there to help reinforce the message. So it needs to be, the whole setup needs to be geared to supporting the recovery. And that's in a sense what reablement is, a whole team led by therapists working with a person to support, to achieve the maximum potential they can achieve for themselves. Next slide, please. So what's been happening to domiciliary care in the last decade? And this is worrying. In my work, I find in many places domiciliary care reablement is not therapy led. And it's absolutely clear where it is not therapy led, the results for older people are much poorer. The outcomes for older people are much poorer. I see figures of around 20 or 30% of people making a recovery. Actually, some research indicates 20 to 30% of people would make a recovery whether or not we had a reablement service or not. In other words, the service that they call domiciliary care reablement actually isn't doing that much in reablement terms. It might be providing good domiciliary care, but not in recovery terms. It's not helpful. And that's not uncommon. There's lots of places, particularly councils who are strapped for cash, particularly in some cases, not in all cases. There are very good examples where councils have put the service, the reablement, domiciliary care reablement service, out into the independent sector, have contractors delivering it, but where therapists from the local authority and the NHS support those providers, perfectly good, perfectly good results. But in some places, the service has been put out into the community and run by the private sector, but they get no support from therapy input at all, and the outcomes then are poor. Exactly the same as I've already suggested around bedded provision. And in a way, it then becomes just ordinary care. And ordinary care is fine, but the evidence is that people are likely to deteriorate if they're just being cared for, if they're not being helped to maximise their independence. There's lots of evidence of that. And it's actually interesting, the recent national audit of intermediate care indicated there is a reduction in reablement that's available to people, both, I mean, I've focused on hospital discharge, but actually these services are equally helpful to people who've been living in home in the community, experience some deterioration, and actually might need a period to help them regain their strength. And in my work, I also found even in hospitals, therapists give up on older people before they're discharged and don't give them the opportunity for recovery or reablement. People kind of make a quick judgment that somebody is struggling in hospital. And of course, we all know about pajama paralysis. We all know what happens to someone when they've been in bed for a while. They lose their strength, they lose their ability. That needs to be picked up. In the best hospitals, that starts when the patient's already in hospital. They start to get mobilising before they leave, but everybody needs that opportunity to support their recovery at the point of discharge. And so in some ways, the confusion about, well, what is reablement? Who should get reablement? There was an interesting study in Torbay in the early noughties, which showed that if the therapist thought someone was reablement ready, a term that developed during that period, they actually found that most likely the person was going to make a recovery without any help. And therefore they actually didn't need domiciliary care reablement. If they were not reablement ready, they were the people who were most likely to benefit from the help that was available. And they found particularly people like hoarders, people with mental health problems, they actually benefited from the attention, from the detail that a really good therapy-led discharge domiciliary care reablement service could offer. Next slide, please. So there is a critique of reablement, it's, particularly in social care. The rhetoric of social care is that social care services should be led by people with lived experience of care, that they are the experts because of their experience of their life condition, and there should be a very strong focus on how they want the services delivered. Whereas actually domiciliary care reablement challenges people. It challenges people about their experience. It challenges people to think differently about their lives, about their experience. And that's a tension for some people who genuinely and understandably believe that actually this should be a service led by people with lived experience. And to some extent, it retains a view the professional may know best for you. And that's kind of a challenge for some professionals and some workers in the care system who do not want the system to be like that. And it doesn't always fit into the liberal thinking on person-centred care. Of course, every domiciliary care reablement package should be a person-centred care package. Every package should be unique to that person, to their circumstances. I had a relation once who, for example, had become an alcoholic. And so her recovery service needed as much to focus on her reduced use of alcohol as much as on whether or not she was going to physically be able to manage her life. It needed to look at all aspects of her life. So actually it does need to be person-centred, but it isn't necessarily, it wasn't at the time what she wanted for herself. We had to intervene as a byproduct of that. At the point she was leaving hospital, she was being assessed to go in a nursing home. She lived a further 10 years in her own home after the interventions she was offered. There is an issue that many councils continue to run this service in-house, and the way they've run the services was at a very high unit cost, and therefore it's seen as an expensive service. And for some councils, when they were strapped for cash, which most councils have been in the last period of time, it has been really hard as to how they sustain this quite high cost service, particularly if they aren't clear, as I'll say in a minute, about what the outcomes that service is delivering. Sometimes there are confusions with similar services run by the NHS, which are not always reablement based. There are some good NHS services, and certainly we've worked in places where there's an NHS reablement service and a local authority reablement service both working next to each other. Not the most useful use of resources or getting the right help to people in the right ways. We always advise people to look to bring those services together to create a single unit, maximise the capacity. And the question still is that in all of my work that people will be familiar with about discharge to assess, one of the biggest challenges is people just aren't commissioning the right numbers of places to meet the demand that's available. And people don't understand always the demands that are going to be available. And certainly in one of the pieces of work I did recently, we showed that actually the biggest challenge in one out of hospital care system was the lack of reablement places available. And therefore people were just missing out on the opportunity, weren't getting the chance of recovery. And there were a number of factors for that, which we could talk about. I would suggest, as I'm saying, that actually in many councils, they haven't developed this service in recent years. And to some extent, without putting blame on them, because money's been so tight, they have found it a service they've disinvested in. They put it out to the private sector, but they haven't put the therapeutic input. And I think that's one of the challenges that faces some places today. Next slide, please. So this is my work on out of hospital care, and it shows that at every level there needs, and all the blue pathways and the purple pathways, those are the services that need to be therapy led and need to be supported by domiciliary care reablement. And it's a significant part of that part of the system. Next slide, please. So one of the features, I think that one of the challenges to domiciliary care reablement is that it's not been very well measured, and many places don't know the impact their domiciliary care reablement is having on people, good or bad. And the better places do tend to know and understand the outcomes they're delivering. They do know how many people in any period of time are making a full recovery, how many making a partial recovery, how many are returned back to hospital, how many, etc. They know that data. Most places don't know the data for their service. And therefore, even in terms of a business case for what should you be investing in the service, if you know the data, if your service is good, if it's getting that 2/3 figure I referred to, you'd bend over backwards to invest in that service. It pays for itself easily, but people don't know. And as I indicated, many services aren't delivering the kind of quality of outcome, and maybe you wouldn't want to invest in those services. Of course, what I would argue is we should make all of the services fit the model, all of them be therapy led, all of them ensure they have specialist staff who are trained in the domiciliary care field, but trained to help people support their recovery. So what we're seeing is a reduction in older people entering domiciliary care reablement. And that's a challenge. But obviously the big measure is what happens to people who go into the reablement programs. This is the simple measure we should be using, and do they require ongoing care and support or not? That would be a simple measure. That's certainly in Coventry, where I live. They have I think it's four now, 4 independent care providers providing their domiciliary care reablement. They are all held to account to achieve a 2/3 target every month, and they've been achieving that for 10 years. Again, what percentage of older people who go into short-term bedded care end up being permanently admitted to a care home? As I suggested, if there's good support available, that figure should be as high as 70%. I've seen figures that are, well, in fact, Somerset achieving the 90%, but I've seen 80s, 90s. But 70 would be a really good target. Again, do we measure that? Do we know that? So I've given the Coventry example, and Somerset. Again, they're both places that really they measure what they're doing. They know what they're doing. They can see the investment. They understand the outcomes and why these services are important. Next slide, please. So, concluding, the key thing is, what I'm arguing is discharge to recover, then assess. Most people do need this opportunity of recovery and recuperation. Many more than people predict will make a recovery if they're given the right opportunity and the appropriate help. Do not give up on people. This can be started in acute hospitals. The process of recovery isn't just what the domiciliary care worker can do. So what about other therapists? It can actually be what the ward staff can do if they have the time and resource to do that. And if you're in a bedded facility, make sure that people have the right help there. Just leaving someone in a bedded facility, even like my father-in-law, where an OT's been in, a physiotherapist's been in, if the staff aren't helped and supported to deliver that ongoing support, their efforts are a bit in vain. Final slide, please. So, reablement is a concept that is used in adult social care, but actually it needs to link really strongly. It's therapy-led and needs therefore to be part of the NHS social care offer. It should become the base of all intermediate care service. The national audit of intermediate care showed that it works best in integrated service models. So where the NHS staff and the social care staff, their therapists are working collectively, collaboratively, developing recovery plans with older people, they can deliver through their domiciliary care reablement teams much better outcomes. This is a well-researched idea used worldwide. I've been in conference calls with people in Australia who use domiciliary care reablement. Again, very similar results in Australia. Last month, I was on a team call like this with a team in Barcelona who were developing it just in Barcelona. It wasn't a Spanish development. It was just by the health services in Barcelona were developing it. And the evidence in all places supports the approach as both cost effective because it produces better outcomes for older people. And therefore, it reduces costs both to the NHS and to social care. But beware. In itself, it's the right idea, but it can be run badly. It can be run cheaply. It can be run with poor outcomes. And of course, the only way you'll know whether it's delivering poor outcomes is if you measure it. If you measure it and you're not achieving the kind of outcomes I've described, then there's something that needs to happen to improve your local service. Thank you. I think it's a final slide with my contact details. If anybody does want to contact me direct, and I've written loads about this, you can see that. You're on mute, Sarah.
Can we shift back, Frankie? Thank you, to do the questions. Thank you so much, John. Absolutely brilliant, really helpful. And I'm really interested in that thing about enabling people to recover enough before we start to re-able them and putting that together, because I think we do forget that in the speed with which we're doing unto people at the moment are really fascinating. And also, I mean, the reflections for your father-in-law. an assessment isn't enough. It's about how we get people around an individual and help them to understand what can be done. We've had some great questions. I'm really grateful, and people do keep them coming. I'm going to go to Sam's question first. And you said, and it's really powerful comment, about 70% chance of people going home with that therapeutic input. And Sam was wondering where the evidence for that came from. And it links also, I'm just going to link this other question to this as well, about whether it is always NHS therapists working with home care, or are there other models of reablement that work with other professionals involved. So just that thing about where does the 70% data come from, and what are the other models of therapy and home care working together? Thank you. Over to John.
Right, two quite different questions. The evidence, it is written up in various places. I wrote up a study that had been done in Kent. It was part of the local government efficiency programme, probably 2004, published by the LGA, looking at efficiencies in social care. That was work undertaken by Newton Europe in Kent. The most recent study I've read, which comes up with very similar figures, this constantly comes up. It's not a peculiar figure. The work that Exeter University did, their study of community hospitals, came up with very similar results. If the hospital was purposefully set up with good therapeutic support, it could achieve 70% plus. The work comes from Somerset, where actually they get 90+% home. So it's kind of fairly consistent figure that comes out in the places who really focus on this and invest in it. So it's not and it's not just my work, other people's work has shown very similar findings. I remember once when I was working in Wales, interviewing 12 care providers for a contract to run intermediate care in a council, bedded intermediate care in a council in Wales, and the providers themselves all offered anywhere between 70 and 80% of people back home as being what they thought their target should be. So those running these kind of services in a proper professional way, that's what they expect to achieve. Other models, I mean, the most common reablement model is not with NHS therapists, it's with local authority therapists. So the occupational therapy working with the customer and with the domiciliary care reablement service. So the most common model is an OT working with the model. I think we've seen over the years that OTs, obviously a massive load of skills, really important, very important part of people in our system. But also we've then found, well, therapists actually are really important, physiotherapists, sorry, are very important part of that ingredient. So again, the better services begin to be integrated. And so, for example, my experience with my father-in-law in Coventry is actually the OT went in, the OT thought of physiotherapy. This could help. So the physiotherapy went in. That would, let's use the skills. Each understands what the other can offer. Let's bring them all to the table. So those are the kind of models. Most models have some kind of therapy, and the best systems, the Somersets, the Birminghams, the Merseysides, they're joint teams of therapists working with frontline care workers called reablement or recovery workers.
Okay, thanks, John. We'll come back, Frankie, and ask some more. Thank you, John. That was really good. Well, putting together some other questions, Callum and Paul particularly have asked about other care groups and whether there are good models of reablement for people with a learning disability. Particularly, Callum has asked about end-of-life care. and just other care groups that might be going through the system, and what models are there out there?
Yeah, and end of life is an interesting concept.
Thank you. Can we go back to John? Sorry, thank you.
End of life is an interesting concept because obviously many older people are coming towards the end of their lives. So how good are we at predicting what that should be? I mean, the general view is somebody who you are clear is at the end of their life. You wouldn't put them through a reablement program. You would want them to die with dignity in a place of their choice, etc. And so reablement is not the right service for those people. Yeah, I mean, I think that would probably be the case. Other groups, well, in a way, that was part of the debate, and the 2005 white paper in social care, which is called Promoting Independence, was about everyone. And it was about having different interventions for different kinds of customers who might need social care. So in a way, you've got in mental health services, for example, you've got a model that's called the recovery model, which focuses on how people can build networks of support to help their recovery from mental health. And that's a kind of an equivalent of a reablement service. Again, was popular at one stage, less invested in. There are one or two places I know have good recovery-based services in mental health services. In other places, the promoting independence model is used to help people, particularly with learning disabilities. There's rehab programs for people who acquire new physical disabilities, and even for people with existing physical disabilities, maximising their independence. So the only place I know where everybody who approaches social care for help gets an OT assessment to look at their recovery is Coventry. So there, whoever approaches social care for help, the first assessment with that person, with that person is, can we do something now to help maximise your independence? And only when that programme of helping people maximise their independence is coming to a conclusion is then the kind of social work assessment process takes over. But even the social workers in Coventry are very committed to continuing the opportunities of maximising independence rather than just what I call giving dollops of care. I don't know of anywhere else that could be proved wrong. I'd be delighted to discover somewhere else that offers that kind of universal service. I say universal, it is for those who are seen as being probably eligible for social care help.
Okay, thank you. Thank you. Can we come back? Okay, thank you, John. That's interesting. I didn't know that about Coventry. That is fascinating. I'm going to wrap up a few questions together here, which is how do we measure the cost effectiveness of reablement, and can digital technology play a part in that? And then the other question that's coming, which I think is linked to this, there's a lot in the questions and really appreciated about the scarce resource that is occupational therapy, and how can we resolve that through integration and working together. But the other question is, do we think 6 weeks is enough for reablement? Should we be putting a time on reablement? And how can we achieve this when we know that resources, both finances and people, are stretched? And I guess, what is it, digital or otherwise, that can help us with that?
Okay, again, lots of questions. The cost effectiveness of reablement is almost it's just looking at the numbers, looking at the outcomes. So if you can reduce your demand on long-term social care in the region of 10%, then there's an investment you might need to make to achieve that, but the payback is greater than the investment. So now, There's a paper I've written on. Is it on that list? No, it's not on that list. If you go to that website, IPC Brooks Publications, there's a whole paper I wrote on managing demand in social care, and that actually kind of shows the maths of what it might look like in relation to how you can take 10% out of the system for a while. It actually then doesn't stay at 10%, it reduces and then begins to flatten out until you find new ways of helping promote independence for people. So it's not a kind of 10% forever. It kind of curve. It's like a curve, but that's all explained in that paper. But it's well worth doing. And the problem is, and very interesting. You see, if you look in the last decade, or sorry, the decade before us, the noughties, there was roughly a 10% reduction in use of domiciliary care. And some people, Age UK, would argue that was terrible. Councils were stopping helping people. Actually, I used to argue, well, actually, that's the kind of figure you'd look like if domiciliary care reablement was working well. Now, of course, we don't know. Which one was it? Was it councils not helping people, or was it helping people really well and reducing their demand? So there's a question, but any council can measure its effectiveness. Is it having an impact? Residential and long-term care, if it's having an impact, there's the business case. The scarcity of OTs, now I agree with that point, though very interesting. I was on a call this morning with some people looking at workforce, and they were saying actually one of the things that many therapists are saying today is that they are not being enabled in their workplaces to offer the help, the direct help to people. They are being kind of administrators of assessments, and that's not job satisfying. In many councils, for example, I've seen this myself, the OT becomes the administrator of aids and adaptations. Now, some of their skills relate to that, but that's a real underuse of their skills. So there's a kind of suggestion in this discussion this morning that actually if we want the workforce of people like therapists, we've got to use them properly. We've got to enable them to actually use the skills they've acquired and be involved directly with customers, directly with care workers, and people get job satisfaction. Coventry run their system perfectly adequately with the OTs they've got. And in a way, of course, with scarce OTs, you then have a workforce who are partially trained. They're not trained like OTs are, but they're trained in the kind of thinking and the delivery of service in the way an OT would, in order that they can help people with their recovery. So they kind of become aids to OTs in a way. It's to overstate the role, but it's so you add to the workforce. And then even more, if you integrate with the NHS, who of course in brackets offer better terms and conditions, you then create a much bigger opportunity, and you begin to see the range of skills that obviously the physiotherapists immediately come into play, but other therapists, dietitians, and others all can play their part if it's an integrated model. So I would suggest, yes, there are scarce resources. There are scarce resources around care workers, but my experience, my conversations with people, particularly with frontline workers, is actually where they are used well and feel they get job satisfaction, they really want to do that and will carry on. It's where they're misused. And I think that applies at all levels, whether you're a frontline care worker, that you begin to get disillusioned and look for something else. So I think if we're interested in workforce, which of course we all are today, then actually how we use the skills people have got in our system and maximise those is such an important part of the message. The 6-week is a nonsense, absolute nonsense. It came in an early DH policy. I remember seeing it. I remember asking when I was in DH, where's it come from? Who said 6 weeks? And I discovered that somebody had discovered that for most hip replacements and knee replacements, it was a 6-week program. So that's where they got it from. And it took about 6 weeks for people to recover, which again, just not missed the point. That there was a study done in Wiltshire, again 10 years or so ago, which showed that actually people's recovery could be over 6 months. it can take quite a while before people sufficiently regain their confidence. So it's kind of, so 6 weeks is, and some people find they recover very quickly, 2 weeks. There's a whole range of domiciliary care reablement services that stop working with people within 2 weeks because they see what is required and they start doing things and they start functioning really well. So 6 weeks is an unhelpful definition unless you've had a hip replacement.
Thanks, John. Frankie, we'll come back. Thank you, John. That was really interesting. And just those two things, we've had a question about the role of occupational therapists. Kate asked what we were doing in the LGA. We have lots of discussions with workforce colleagues, both nationally and as part of the peer reviews we do, running workshops and others to look at what is the role of the OT, occupational therapists, other therapists, and how can systems work together, organisations work together to look at that workforce and how they develop it. But I'm really interested in what you were saying, John, because it's come out as a lot of the work we've done on discharge, just how dissatisfied some professional colleagues feel with the kind of chasing the numbers, filling in the forms, doing all of that rather than having the time and space to do that really personalised work, but also have the conversations they need to have with people, and that be families or the person themselves about what the options are. And, you know, help them, support them. As a social worker, you spend hours with people supporting them to make a really difficult decision. And we just don't seem to be giving our staff or enabling our staff to be able to work in that way. And no wonder they then leave. And you know, some shocking figures this week about how many people are leaving because they feel that demoralised. But also we're not attracting people into the work that we want to attract in, and there's obviously an issue about funding that, but there's also an issue about the role itself and what are we asking people to do. Feel that really strongly from some of the reviews we've done. I think the other bit about the 6 weeks is also really interesting, and that bit about being really personalised, and that takes time as well. To be able to work with people in that personalised way. But it's a false economy if we don't make that opportunity for staff to have that time to do that work. And so when we're developing the systems together, it's being able to have that flexibility. What are the services that we need to commission to enable people to recover and then have reablement? You know, what's the sort of flexibility that we need to build into contracts and commissioning to enable the providers of those services and the assessors to make the decisions that they need to make with the person and not be constrained by everybody has this, then they have this, and then they have that, which is often a waste of that valuable resource. We have got some other questions. We're not going to get through them all today. So what we will do is make John do some more work. We'll get the questions to him and then we'll email around the answers to colleagues who've attended this, who've registered for the webinar. Can I just say a huge thank you to John? That was so interesting and so helpful. Really appreciate your time. I hope others found it as interesting as I did, and I know you will have done. Thank you for attending. Thank you for contributing. As I say, we'll answer all your questions. We'll have another learning lunch in July and we'll be putting out the information for that. But if you've got any good ideas, colleagues, or you want to hear someone speak on a particular subject, please do contact us, or you want to showcase what you're doing. That's what we also really like to hear. So thank you again. John, brilliant. Thank you very much and look forward to our next session. Huge thanks to Frankie and Fiona in our team at the LGA who have managed the tech behind this today. Thank you very much, colleagues. Bye-bye.